My name is Andrew Chou. I'm a health services researcher and emergency physician from the Brigham and Women's Hospital. Thank you for your interest in our project, which examines the impact of hospital occupancy on emergency department care. This project was supported by the Emergency Medicine Foundation Practice Intensity Grant that aimed to examine the changing practice of emergency medicine and assess its value. Emergency department care has grown in intensity across many aspects, including increased advanced imaging use, expanded critical care capacity, observational medicine, outpatient acute care pathways, among many other services. With this expanded capacity, though, it has drawn a lot of criticism about the high cost of emergency care. However, whether ED care with these expanded capacity provides value is really unknown. One potential way that these higher intensity care can produce cost savings and value is through avoided hospitalizations. Inpatient care accounts for nearly 1/3 of the U.S. healthcare expenditure. Despite this, hospital bed shortage has been an ongoing crisis in the U.S. healthcare system. Numerous research have demonstrated that hospital occupancy is one of the primary contributors to emergency department crowding. With a growing crisis of ED crowding, worsening hospital bed shortage, growing healthcare costs, emergency clinicians may be delivering higher intensity care to avoid hospitalization as well as ensuring safe discharge. My hypothesis then is that high hospital occupancy associated with increased ED care intensity as measured by longer length of stay, more laboratory studies, advanced imaging use, medications administered, and high complexity bills. We analyzed the clinical and administrative data of an emergency department of a large academic medical center, namely the Brigham and Women's Hospital. We combined the following three datasets. First, we obtained the electronic health records of all ED visits between October 2010 and May 2015, and the cutoffs are really due to data availability. This included approximately 300,000 ED visits. We combined this with the billing data from the administrative section of the emergency department and linked each visit to its associated E&M codes. Lastly, we obtained daily hospital administrative data, which record hospital census as well as the occupancy, meaning census divided by available beds, at midnight each day. We used this data to build an ED visit level data. With patients' home zip code, we also linked each visit to census socioeconomic statuses, including employment, income levels, and educational attainment. We also grouped each visit sheet complaint into broader but meaningful categories with review of 2 emergency clinicians. Lastly, we linked each visit to associated E&M codes as we mentioned, as well as the hospital occupancy from the previous night, from midnight before the ED visit day. Primary outcome, accordingly, includes measures of length of stay by minute, number of laboratory studies per visit, number of advanced imaging per visit, medications, and proportion of visits that were high complexity bills, defined as these billing codes. We performed descriptive statistics stratified by quartile of hospital occupancy to identify any visit characteristics that may materially be different between hospital occupancy levels. We then used multivariable regression using either negative binomial or logistic regression as appropriate to predict outcome rates as predicted by hospital occupancy levels. We adjusted for visit characteristics, patient characteristics, time variables, as well as physician fixed effects, because physicians do vary significantly in their practice and resource utilization patterns. Lastly, we also included fixed effects for the 20 most common chief complaint categories to control for any case mix. Notably, we included these as variables that would have preceded the visit, information that may be available to the clinician and treatment team before the ED visit. Dividing ED visits by the level of hospital occupancy, we can see that majority of the visit characteristics from the patient's perspective are fairly similar without really substantial differences. Notably, there's weekly trends where weekends tend to be less crowded, and during the week there's high hospital occupancy. Hospital occupancy also have overall increased over the years during the study period. Here, dividing by hospital occupancy levels, we found that the case mix largely is fairly similar across the levels of hospital occupancy. In adjusted analysis, we found that nearly all measures of practice intensity increased with higher hospital occupancy, which appears most pronounced for length of stay. For other measures, the dose-dependent relationship with hospital occupancy appears mostly limited to the first three quartiles. When we limited our sample to only physicians that have been at Brigham for the past 4 years, the results were pretty similar. However, when we explored by examining its association with the occupancy measured after the ED visit, the association still stands and appears actually stronger. We believe these results support that hospital occupancy is associated with increased care intensity. However, the causal direction is less clear. High hospital occupancy can possibly lead to high care intensity. However, high care intensity may also contribute to high hospital occupancy. In our preliminary analysis, the latter appears to have stronger association as well. However, these two possibilities may not be mutually exclusive and may concurrently be in effect. Future research is needed to further clarify this relationship. One idea is to do a real-time operational study to examine clinical decision-making in real time. On a larger scale, natural experiments that leverage clinician variation can also be done to elicit the causal link between hospital occupancy and ED care intensity. Thank you for your attention. Please do not hesitate to reach out for any questions.